Hi, my name is James, and today we're going to talk you through everything got to do with navicular stress fractures. We're going to talk you through how they happen, what sort of symptoms you get, how to treat them, and most importantly, how to diagnose them, because we know they're one of those foot conditions that go undiagnosed for a long period of time, and if that is the case, it can cause a lot of trouble, difficulty with healing, and lead to surgery. So the first thing I want to look at is the anatomy of the navicular bone. As you can see, it sits right in the middle of the foot. Some people consider it the keystone of the medial longitudinal arch of the foot. One of the interesting things about it is that it has a unique blood supply. So as you can see from the diagram, it gets one blood supply that goes inward, then it splits to the left and to the right, medially and laterally, and it leaves a vacant position in the middle of the bone that has less blood supply, and that struggles to heal when you have a stress fracture. So how do people get a navicular stress fracture? Well, we know it's more prevalent in males than females. We know that in a study of 200 people, they found that 98.5% of those that occurred in were athletes. So we're looking at sports that have impact. So running, jumping, gymnastics, all increase the force that go to the medial longitudinal arch of the foot, places excess stress on the navicular, and can cause a bending-like effect on the bone, increasing your risk of a stress fracture. We know that if you have conditions such as osteopenia or osteoporosis, that you have an increased likelihood of stress fractures, and that's the case for navicular as well. We should look at other things such as relative energy deficiency in sport. In the description below, we'll link an article about relative energy deficiency in sport, so you can increase your understanding of this. So what are the symptoms of a navicular stress fracture? Well, the most common symptoms are gradual onset of pain that develops slowly as you work through impact activity. So typically patients present with a dull ache in the arch of the foot that becomes more persistent and consistent over time. Often it's pain-free at rest with immediate onset of pain upon impact, and patients really struggle with landing from jumping activities such as gymnastics or when they make contact with the ground during mid-stance while they're running. We'd expect the pain to get worse with increased activity rather than better, like you would see in some tendon pathologies. There may be some redness and swelling around the area, but that's not always the case. But typically it's distinctively tender to touch on the navicular bone. And that also brings us into our diagnosis. So we have one special test that we know as the end spot. So the end spot is a tender point at the top of the navicular, covering about 19 millimeters in diameter, slightly towards the ankle joint. And we know if we press on that, there's a really high sensitivity of about 81% that you have a navicular stress injury. Other symptoms that we look to help with our diagnosis as clinicians is the inability to single leg hop without pain, and often there's even pain on a single leg calf raise. So if we have a clinical suspicion of a navicular stress fracture, we often refer for imaging. Typically that begins with an X-ray, and we know that they're not the most sensitive forms of imaging. So if that returns as normal, we often refer onward for an MRI scan. This gives us an insight not only to the health of the bone, but into the surrounding tissues, so the muscles, ligaments and tendons in the area. And if there's an increased suspicion, a negative result on the MRI scan, then we know the gold standard of imaging is a CT scan for a navicular stress fracture. Now these have to be carefully monitored, carefully diagnosed, and done as promptly as possible. As a result of the divergent blood supply into the bone, it's a high risk stress fracture site. So that means that when we identify it, it goes straight into a boot, and typically these patients are asked to non-weight bear, so they use crutches as well. So the period in the boot is normally 6 to 8 weeks at a minimum. 2 to 4 of those weeks may be non-weight bearing, and then you progress on to partial weight bearing before returning to weight bearing, typically with cushion shoes inside a house initially. Then you might progress on to 10 to 15 minutes outside and increasing your step count from there. Due to the long period of time that you'd spend in a boot, we'd often recommend banded exercises to begin with initially. These should be under the supervision of a physical therapist or podiatrist. These help to reduce the risk of muscular atrophy after a long period of time in the boot. They help to maintain your neurological drive into the area, and then they also help to speed up the process on the other side.